most important part of the scan, which is called as the NT scan, where we are going to measure the nuchal translucency. The measurement of this parameter is important because this is a genetic scan and we are going to base our rest of the tests on the basis of the finding of the scan. So baby needs to be in optimal position, and sometimes you'll notice that your doctor will say baby is not in position and will ask you to empty your bladder, come back after some time. Do not panic if something like that happens. It's absolutely normal for NT scans, etc., to take time. And sometimes if you are lucky and baby is cooperating, then the scan can be done within half an hour also. So once we take the measurement according to the guidelines, international guidelines of the Fetal Medicine Foundation UK, which we are all universally following, we chart our findings. So we take the NT scan findings against the baby's length and a graph is generated. And most of our findings we expect should fall below the 95th percentile because the findings are relative to the baby's length. And overall, roughly, if you were to ask me what the length should be, usually the length should be somewhere below 3 mm. If it is coming anywhere closer to 3 mm, we get worried. Sometimes between 2.5 to 3 mm also shows an increased risk if it's a very small baby, if it's only 11-week baby. Therefore, it's essential to plot it against the baby's length. What happens after we have plotted the graph? After we have checked how the baby's nuchal translucency is and where it is falling, we have software with us which is going to tell what is the risk going to be for this baby to have certain common conditions, which is called as Down syndrome. I'm sure you've heard about Down syndrome. It is a trisomy 21, which means that there is an extra pair of chromosome on chromosome number 21. Chromosomes are where all our genetic material is stored inside our cells, and all of us usually have 46 chromosomes or 23 pairs of chromosomes, where 23 are coming from each parent. Sometimes, unfortunately, babies can have extra chromosome, which is what makes it a trisomy. And the most common conditions which are associated with increased NT and trisomy are in the chromosome number 21, sometimes on 13 and 18 as well. But that does not mean the other conditions are excluded. Therefore, a thorough examination of the fetus is essential. So after plotting our graph, and if we do notice that the NT is coming increased, which can happen in some normal babies, 1 in 20 babies will have an increased NT. That does not mean that all the babies are sick. We have to find out which are the babies who will need extra testing, which are the babies who are really having chromosomal problems. Because some babies where other organ systems are involved, for example, the heart is involved, they may show this kind of a picture, or sometimes everything may be normal yet they may have an increased NT. But just purely on the basis of scan, we may not be able to segregate that. Therefore, we need to add something extra to our scan. And what is that extra thing we are going to add? That is called as a blood test or a biochemical test, where on the same day, usually on the same day, if the mother is prepared for it or if she's appropriately counseled, what we do once the scan is done, we send the mother to our labs which are equipped to take mother's blood, and we check for 2 to 3 hormones are checked, and on the basis of these hormones, which is beta-HCG and PAPA, we come up with a figure which is called as a combined screening, because these hormone levels tend to be disturbed in babies who have chromosomal problems. Therefore, we club all these together, taking mother's age into consideration, the baby's length, baby's heart rate. We take nuchal translucency. We also look at the presence or absence of nasal bone, because it is noted that many times these babies do not tend to have a well-formed nasal bone. It may not be very well calcified. It may not be as bright as it is expected to be, or sometimes it forms late. So that itself becomes a marker. So that is also taken into consideration. Also, other markers are taken into consideration, like we examine the heart thoroughly, and if there are any leaky valves in the heart, which is called as a tricuspid regurgitation, where the right-sided valve is leaky. So those particular cases we document, and we check the blood vessel which goes to the heart. This is called as a ductus venosus. We check the blood flow into it, and if there is any reversal or if there is any increased resistance to that blood vessel, then that also becomes a marker. So taking all these markers into consideration, we plan everything, we club everything together, and we come up with a combined risk. Now, what is a combined risk? Combined risk risk tells us about how likely it's a probability ratio. It's not going to tell if the baby has a condition or not. So do not panic if the risk is coming like an increased risk or an intermediate risk for a certain condition, because this is taking a lot of factors into consideration. We are trying to narrow down on babies who will require further testing. Therefore, we take this combined risk, and let me explain you more clearly. Say if the risk for a particular baby has come 1 in 2000, which means if there were 2000 mothers and babies with similar tests, if they were all put together, only one baby is likely to have a Down syndrome, which is still a low risk, right? So this is how we will explain to you how probable this baby is to be acquiring these chromosomal problems. So once the risks are calculated,